Get in the game with the college-branded Venmo debit card. Wreck your team with every tap and earn up to 5% cash back with Venmo Stash, a new rewards program from Venmo. No monthly fee, no minimum balance, just school pride and spending power. Get in the game and sign up for the Venmo debit card at venmo.com/collegecard. The Venmo MasterCard is issued by the Bancorp Bank N.A. Select schools available. Venmo Stash terms and exclusions apply at venmo.me/stash terms. Max $100 cash back per month.
It's crunch time at work, and you need to bring wings to your workday. Visit redbull.com/gettingitdone and answer a couple questions about your work style to get a Spotify customized playlist tuned to your productivity. Plus, score a can of Red Bull on us while you go from to-do to done. And remember, Red Bull gives you wings. Supplies are limited. Terms apply. Visit the website for more information.
Hey everyone, Chris here from MedPrep2Go, and welcome to our USMLE Step 2 Questions podcast. In this episode, I'll be reading endocrinology questions 7 through 9, and just a quick reminder that you can read these questions and more at medprep2go.com. Also, while you're there, check out the new search feature to find what you want to study faster. And with that being said, let's get started with question 1, Endocrinology 7. An 18-year-old woman presents to the emergency department with lethargy for 10 days and abdominal pain for the past 2 days. She feels that she has lost weight as her clothes have become loose. She mentions that she is always thirsty and has to go to the bathroom 3 times in the middle of the night. Her last menstrual period was 2 weeks ago. Past medical history is negative and she does not take any medications. She does not consume alcohol or use illicit drugs. Vital signs are temperature of 98.6 degrees Fahrenheit or 37 degrees Celsius, blood pressure of 108/66, pulse 110 beats per minute, and respirations of 20 per minute. On physical examination, she has dry mucous membranes and tachycardia. She has diffuse abdominal tenderness to palpation but no rebound or guarding. Which of the following is the most appropriate next step in the management of this patient? Is it A, abdominal X-ray? B, blood culture and antibiotics? C, dextrose saline infusion? D, fingerstick blood glucose measurement? Or E, subcutaneous insulin administration? And the correct answer is D, fingerstick blood glucose measurement. The patient's symptoms of lethargy, weight loss, excessive thirst, polydipsia, and frequent urination, polyuria, are classic signs of diabetes mellitus, particularly diabetic ketoacidosis, DKA. Type 1 diabetes mellitus often presents in young patients, and DKA can be the initial manifestation. If left untreated, DKA can lead to severe complications such as altered mental status, hyperventilation, and abdominal pain. The best initial test is to perform a fingerstick blood glucose test while waiting for the plasma glucose level to confirm hyperglycemia. In cases of DKA, blood glucose levels are typically above 300 mg per deciliter. Additionally, an arterial blood gas test will usually show metabolic acidosis, which is a bicarbonate less than 18, with a high anion gap. Ketones may also be present in both serum and urine. Upon diagnosis, fluid repletion may be initiated with isotonic saline, 0.9% sodium chloride, or isotonic buffered crystalloid and insulin to reduce blood glucose levels. Potassium should also be administered if the serum potassium level is less than 5.3 to prevent hypokalemia during insulin therapy. If the initial serum potassium is 3.3 to 5.3, intravenous KCI of 20 to 30 milliequivalents is added to each liter of intravenous replacement fluid. Adjust potassium replacement to maintain the serum potassium concentration in the range of 4 to 5 milliequivalents per liter. Most guidelines recommend initiating treatment with low-dose IV insulin in all patients with moderate to severe DKA who have a serum potassium greater than or equal to 3.3 milliequivalents per liter. The only indication for delaying the initiation of insulin therapy is if the serum potassium is below 3.3 milliequivalents per liter, since insulin will worsen the hypokalemia by driving potassium into the cells. Subcutaneous insulin protocols are being used with increasing frequency to treat selected patients with mild to moderate DKA. Treatment of DKA with subcutaneous insulin has not been evaluated in severely ill patients. In mild DKA, direct comparison of intramuscular, subcutaneous, and IV insulin therapy for hemodynamically stable DKA patients shows similar efficacy and safety. Answer choice A. Abdominal X-ray is incorrect. An abdominal X-ray is not indicated as the initial test because the symptoms described, lethargy, weight loss, polydipsia, and polyuria, are more suggestive of a metabolic disorder rather than a primary gastrointestinal issue. Answer choice B, blood cultures and antibiotics, is incorrect. There are no obvious signs of infection such as fever, making blood cultures and antibiotics inappropriate as the first step. Answer choice C, dextrose saline infusion, is incorrect. Administering dextrose saline infusion without knowing the patient's blood glucose level could worsen hyperglycemia if the patient is experiencing diabetic ketoacidosis. Answer choice E, subcutaneous insulin administration, is incorrect. While insulin is necessary for treating DKA, it is not administered before confirming blood glucose and serum potassium levels. Key learning point: lethargy, weight loss, polydipsia, and polyuria are classic signs of diabetic ketoacidosis, DKA, a serious complication of diabetes mellitus, usually from type 1 diabetes. The best initial test to confirm hyperglycemia and diagnose DKA is a fingerstick blood glucose test while waiting for the plasma glucose level. Question 2, Endocrinology 8. A 19-year-old woman presents to the emergency department with 1 week of lethargy and 1 day of diffuse abdominal pain. She also reports a 10-pound weight loss as well as frequent urination and excessive thirst. Her last menstrual period was 3 weeks ago. Past medical history is unremarkable and she does not take any medications. She does not consume alcohol, smoke cigarettes, or use illicit drugs. Her vital signs are temperature of 98.6 degrees Fahrenheit, or 37 degrees Celsius, blood pressure of 114/62, pulse of 15 beats per minute, and respirations 24 per minute. On physical examination, she has dry mucous membranes, tachycardia, and tachypnea with a fruity odor to her breath. Abdominal examination reveals diffuse tenderness to palpation with no rebound or guarding. Fingerstick blood glucose level is 390 milliequivalents per liter. Further lab results show a potassium level of 5.4 milliequivalents per liter, bicarbonate of 14 milliequivalents per liter, and a pH of 7.24. Which of the following is the most appropriate next step in the management of this patient? Is it A, half normal saline and regular insulin infusion, B, half normal saline and subcutaneous insulin administration, C, normal saline and regular insulin infusion, D, normal saline and subcutaneous insulin administration, or E, sodium bicarbonate and normal saline and regular infusion? And the correct answer is C, normal saline and regular insulin infusion. Diabetic ketoacidosis severity is determined by the pH level, bicarbonate level, and mental status of the patient, not by blood glucose measurements. Moderate to severe DKA is categorized as follows. Moderate DKA is a pH level between 7.0 and 7.24 and a sodium bicarbonate level of 10 to 15 milliequivalents per liter. Severe DKA is pH level less than 7 and a bicarbonate less than 10 milliequivalents per liter. In a patient presenting with diabetic ketoacidosis, fluid repletion may be initiated with isotonic saline, which is 0.9% sodium chloride, or isotonic buffered crystalloid, such as lactated Ringer solution. Dextrose 5% is added when serum glucose is less than or equal to 200 mg per deciliter. Most guidelines recommend initiating treatment with low-dose intravenous insulin in all patients with moderate to severe DKA who have a serum potassium greater than or equal to 3.3 milliequivalents per liter. A switch to subcutaneous basal bolus insulin is made when the patient can eat and the glucose level is below 200 mg per deciliter. Bicarbonate is considered for patients with a pH less than or equal to 6.9 and is rarely indicated. Other options are less appropriate. Answer choice A, half normal saline in regular insulin infusion, is incorrect. Half normal saline in regular insulin infusion is not appropriate because half normal saline is not the initial fluid of choice. Answer choice B, half normal saline in subcutaneous insulin administration, is incorrect. Half normal saline is not the initial fluid of choice. Normal saline is usually preferred. Additionally, subcutaneous insulin administration is not appropriate for initial management of moderate to severe DKA, which requires IV insulin. Answer choice D, normal saline in subcutaneous insulin administration, is incorrect. While normal saline is correct for fluid resuscitation, subcutaneous insulin is not appropriate for initial management. IV insulin is required to rapidly control hyperglycemia in moderate to severe DKA. Answer choice E, sodium bicarbonate with normal saline and regular insulin infusion, is incorrect. Sodium bicarbonate is only indicated in severe acidosis, which is pH less than or equal to 6.9. Without this indication, it should not be used routinely in DKA. Key learning point. In the setting of DKA, fluid repletion may be initiated with isotonic saline or lactated Ringer solution. Continuous IV insulin should be administered to treat hyperglycemia in moderate to severe DKA. Insulin should be continued until the anion gap resolves. Potassium levels should be monitored, and potassium should be administered if the level falls below 5.3 milliequivalents per liter. Sodium bicarbonate should only be used for severe acidosis, which is pH less than or equal to 6.9.
Eczema is unpredictable, but you can flare less with Ebglyss, a once-monthly treatment for moderate to severe eczema. After an initial 4-month or longer dosing phase, about 4 in 10 people taking Ebglyss achieved itch relief and clear or almost clear skin at 16 weeks. And most of those people maintain skin that's still more clear at 1 year with monthly dosing.
Ebglyss, lebrikizumab LBKZ, a 250 mg per 2 milliliter injection, is a prescription medicine used to treat adults and children 12 years of age and older who weigh at least 88 pounds or 40 kilograms with moderate to severe eczema, also called atopic dermatitis, that is not well controlled with prescription therapies used on the skin or topicals, or who cannot use topical therapies. Ebglyss can be used with or without topical corticosteroids. Don't use if you're allergic to Ebglyss. Allergic reactions can occur that can be severe. Eye problems can occur. Tell your doctor if you have new or worsening eye problems. You should not receive a live vaccine when treated with Ebglyss. Before starting Ebglyss, tell your doctor if you have a parasitic infection.
Ask your doctor about Ebglyss and visit ebglyss.lilly.com or call 1-800-LILY-RX or 1-800-545-5979.
So good, so good, so good.
Spring styles are at Nordstrom Rack stores now, and they're up to 60% off. Stock up and save on Rag & Bone, Madewell, Vince, All Saints, and more of your favorites.
How did I not know Rack has Adidas?
Why do we rack? For the hottest deals. Just so many good brands.
Join the Nordy Club to unlock exclusive discounts, shop new arrivals first, and more. Plus, buy online and pick up at your favorite Rack store for free. Great brands, great prices. That's why you rack.
Question 3, Endocrinology 9. A 40-year-old woman presents to the clinic for follow-up of hypertension, which has been difficult to control despite several antihypertensive medications. Her blood pressure is consistently measured between 160/100 and 180/110 during multiple visits over the past several months. She reports feeling fatigued and has noticed muscle weakness over the past few months. Past medical history is negative other than the hypertension. She currently takes amlodipine and hydralazine. She had side effects from hydrochlorothiazide and lisinopril, so these medications were previously discontinued. Laboratory results reveal the following: sodium of 145 milliequivalents per liter, potassium 2.8 milliequivalents per liter, chloride 100 milliequivalents per liter, bicarbonate 30 milliequivalents per liter, glucose 100 milligrams per deciliter, creatinine 0.8 milligrams per deciliter. A CT scan of the abdomen shows a 2.5 centimeter mass in the right adrenal gland. Which of the following additional findings would be expected in this patient? Is it A, high plasma renin activity, high serum aldosterone, high serum bicarbonate? B, high plasma renin activity, high serum aldosterone, low serum bicarbonate? C, low plasma renin activity, high serum aldosterone, high serum bicarbonate. D. Low plasma renin activity, high serum aldosterone, low serum bicarbonate. Or E. Low plasma renin activity, low serum aldosterone, high serum bicarbonate. And the correct answer is C. Low plasma renin activity, high serum aldosterone, high serum bicarbonate. This patient's presentation of hypertension, hypokalemia, and a unilateral adrenal mass is highly suggestive of primary hyperaldosteronism, otherwise known as Conn syndrome. Primary hyperaldosteronism is characterized by the excessive and unregulated secretion of aldosterone from the adrenal glands, commonly due to an adrenal adenoma or bilateral adrenal hyperplasia. Aldosterone increases renal reabsorption of sodium, which leads to an increase in total body sodium. Despite this, serum sodium is usually normal or mildly elevated because of a compensatory increase in antidiuretic hormone ADH. Since the hypothalamic pituitary adrenal axis is intact, and as serum osmolarity increases, so does the release of ADH. This is why a normal serum sodium is seen in a Conn syndrome. The elevated levels of aldosterone results in the suppression of renin release from the kidneys, resulting in low plasma renin activity. Aldosterone also promotes potassium excretion, leading to hypokalemia, which can cause muscle weakness and fatigue. Furthermore, aldosterone stimulates hydrogen ion secretion, resulting in metabolic alkalosis, reflected by elevated serum bicarbonate levels. Answer choice A, high plasma renin activity, high serum aldosterone, high serum bicarbonate, is incorrect. Elevated renin activity would be inconsistent with hyperaldosteronism. Answer choice B, high plasma renin activity, high serum aldosterone, low serum bicarbonate, is incorrect. This pattern would be more consistent with secondary hyperaldosteronism, where renin activity is elevated due to conditions such as renovascular hypertension. Answer choice D, low plasma renin activity, high serum aldosterone, low serum bicarbonate, is incorrect. Low serum bicarbonate would suggest an acidosis rather than the metabolic alkalosis that is expected in primary hyperaldosteronism. Answer choice E, low plasma renin activity, low serum aldosterone, and high serum bicarbonate, is incorrect. Low serum aldosterone would not fit with the clinical scenario of primary hyperaldosteronism. Key learning point. Primary hyperaldosteronism is characterized by resistant hypertension, hypokalemia, and possibly an adrenal mass, low plasma renin activity, high serum aldosterone, and high serum bicarbonate due to metabolic alkalosis. And that will conclude this episode of our USMLE Step 2 Questions podcast. I hope you enjoyed it and found the information useful. Please be sure to follow us at MedPrep2Go on LinkedIn, Facebook, Instagram, and YouTube to stay up to date with our content. You can learn more and read other Step 2 questions at medprep2go.com. Happy studying!
The UPS Store is making packing and shipping Easter gifts quicker than ever this year with UPS Air. How quick? Quicker than a walk around the park. Quicker than eating all the Easter candies. Quicker than finding a golden egg that you know is stuffed with cash. When you ship UPS Air at the UPS Store, your items arrive on time or your money back. Guaranteed at no extra cost. Exclusively at the UPS Store US retail locations. Send Easter joy on time at the UPS Store. Visit the upsstore.com/air guarantee for full details. Terms and conditions apply.
Hey everyone, Chris here from MedPrep2Go, and I wanted to ask you to please follow us on social. There may be links in the show notes, or you can find us at MedPrep2Go on Facebook, Instagram, LinkedIn, and now YouTube. We'd greatly appreciate it as we try to spread the word about MedPrep2Go and keep medical education accessible and affordable.